All right, good morning. Hello, everybody. Welcome back from break. I hope it was good for everybody. We are going to dive into Chapter 1 of Basic Pharmacology. This is a great book. I hope you've all looked through it a bit. It's going to be a good class. You guys are going to do great with this. So to start off, what is pharmacology? Pharmacology is the study of interactions between chemicals and biological systems. Now, when we're using chemicals to treat diseases, that's when we call them drugs. So you will hear that a little bit interchangeably throughout this course, chemical versus drugs. We're meaning the same things, especially when we're talking about treating diseases. All right, so let's dive in. The first thing we're going to talk about are drug sources. There are three sources of drugs, the first one being the natural sources. These are coming from plants, animals, and minerals. And these here listed are a few basic examples. A good example for plant-derived are going to be atropine and morphine. Atropine is an anticholinergic. It's given to patients before anesthesia to decrease the mucus secretions and regulate their heart rates. And that does come from plants. Morphine is another one, like I said, that's plant-derived. This is an analgesic, and it's given for pain relief through their IV post-op. Right? Animals provide another source for drugs as well, particularly hormones. And these were the best that we had available before biotechnology came into play. You'll hear some two common ones. If it refers to coming from cattle, it is bovine, B-O-V-I-N-E, bovine. And if it comes from hog, it is porcine, P-O-R-C-I-N-E, porcine. Okay? And a couple of examples of these are thrombin. That's a topical hemostatic, and that is bovine in nature. Then we have proloid, which is used to treat thyroid disorders, and that is porcine in nature. Another one that we have is Premarin. This is an estrogen cream. We use it a lot for vaginal packing. And that one actually is equine in nature. They discovered and took it from the urine of pregnant horses. So that's another example of an animal-derived source. Okay, and then finally we have minerals. And these are pretty common. These are your over-the-counter type Tums for calcium, Milana, is magnesium based. And then we also have another one that is Silvadene cream, and that is silver based. We use that to treat burns and burn patients. Okay, next we have chemical sources. These are usually put together in a lab, and they can be either synthetic or semi-synthetic. So Demerol is a good example of a synthetic chemical drug. It's put together in a lab. It's used for pain relief. It's similar to opioids, but it is made in a lab. Okay. And then we have the semi-synthetics. These drugs start with a natural substance, but then are chemically altered in the lab. So for example, penicillin, it's originally from a natural mold, but the active substance that's extracted and purified in the lab, and that's where we get penicillin from. And finally, we have biotechnology. So biotechnology is a little bit different in that it allows scientists to produce proteins from bacteria by altering DNA. Okay. So for example, E. coli, we can physically insert a gene into the DNA of an E. coli cell. And what that gene does is codes or makes copies for a certain bacteria. And this process happens very quickly. So that allows for large volumes of that protein to be obtained very quickly by the scientists. Okay, the protein's extracted, it's purified, and it's prepared for administration then. Another one that is mentioned in your text is the CHO, Chinese hamster ovary cells. These are mammalian cell lines. They're used to produce therapeutic proteins like Humira, which helps with inflammation that can lead to Crohn's disease. So Humira is used with the CHO. CHO is becoming the primary choice for cell lines. They're more stable gene expression. They have higher volumes of the desired proteins. So those are becoming very, very popular. That's the main source where we're getting things from. Okay, some others include from CHO the Hep B vaccine, human insulin growth hormone, thyroid stimulating hormone. Those are all derived from biotechnology. Something that needs to be noted about biotechnology is that these have to be administered by injection. Okay, these can't be taken orally because they are proteins. And if you remember way back from your anatomy and physiology, when we take proteins orally, they're instantly digested when consumed. So we can't be having that happen if we're taking these types of drugs. So these are done by injection only. And another good thing to note about biotechnology-based drugs are that there are no adverse side effects with these. And we will go through a little later what an adverse side effect is, but there are none of those with these particular drugs. Okay, next we're going to go through some drug classifications. These are used to group drugs together by a similar purpose. And page 4, table 1.2 has a really good that's a really good table that lists out different drugs and their classifications and what they do, okay? Some might be listed in multiple classes, like aspirin. We'll get into that in just a minute, okay? And a good note, when we're talking about drug classifications, use your medical terminology. That's a really easy way to break down drugs and break down their names rather, and come to a conclusion as to what they do or what they might treat, what they might be used for. So for example, a vasoconstrictor. This causes blood vessels to contract, restricting the blood flow. If you break that down, we've got vaso, which means vessel, and then constrict. So that's an easy way to break that down and figure out what that does. Okay, and like I said, some might be listed in multiple classes like aspirin. It relieves pain, it's a fever reducer, and it's an anti-inflammatory. So it's classified as an analgesic, an antipyretic, and an anti-inflammatory. So that's what I mean by some may have multiple things that they do, so they are listed in multiple classes. Okay. So broader classifications by what they do and what they affect and what they are. That's what we're going to get into right now. So first off, there's therapeutic. Okay, this is what they do for a patient. Okay, some examples are analgesics. They relieve pain. Anticoagulants. They help prevent blood clots, such as our heparin. Okay, those are therapeutic classifications. Then we have physiological. This is what they do in the body. So histamine receptor antagonists block histamine production. You'll hear this a lot tied in with your anti-allergy pills, Benadryl. It's a histamine blocker. Okay. Antagonists are known as histamine or as receptor blockers. So this is where your antagonists are going to fall in. They are physiological. They are histamine receptor antagonists. That's where you'll hear that. And we have the body system. This is what they affect. Okay, so cardiovascular agents. They affect the heart and the circulatory system. So for example, in surgery, we may give a atenolol to treat high blood pressure or angina, which is chest pain. Okay, that's a similar, or a common one that we use in surgery. We also have chemical. This is what they are. For example, barbiturates. These are used to inhibit the central nervous system. They're used to treat seizure disorders. We also can group hormones and narcotics and steroids into this group. These are the chemical type. Okay, these drugs can also be classified by how they're attained. So that means that they can be either prescription or over the counter. There's also some classifications for controlled substances. Okay, but these are the three main that I want you to really focus on. All right, so then we're going to get into some medication orders and what we do with them in surgery. There are a few, as you can see here. These are the 4 main ones that we're going to do. And I do want to make note that on page 5, table 1.3, there's a med administration abbreviations. That is a very good table that I want you to take note of and study, because we'll hear those and use those quite a bit during this class, okay? All right, so standing order. This is just protocol. These are things that are used in common situations needing standard treatment. Okay, a lot of hospitals, if they're working with JCO for accreditation, you might hear about the Surgical Care Improvement Project, or SCIP is what they'll call that. And what that means is that all patients receive a prophylactic antibiotic an hour before surgery. This is a preventative antibiotic. So for example, a hospital participating in SCIP may give all total joint patients 1 gram of Ansef an hour before surgery. And that is just a preventative antibiotic to help fight those surgical site infections. Okay, these are going to be listed on the preference card. They might be, for example, a AAA card. May have a standing order for 5,000 units of heparin and 1,000 milliliters of saline for irrigation. If it's on the preference card, this lets us know that it should be on the back table at the beginning of the procedure and ready for use. If it's on that card, they're going to use it every time. It is a standing order. It is protocol. Okay. So we have verbal orders. These are common in surgery. We use them a lot. And this is basically the doctor or the surgeon requesting that a drug be given either from the field or by the anesthesia care provider. Okay, these are usually a one-time occurrence, and it is documented in the patient record that it's given by either the anesthesia or the nurse. An example of this would be during a carotid. If we're doing a carotid endarterectomy, before applying the vascular clamps to that carotid artery, the surgeon may ask anesthesia to give 5,000 units of heparin through the IV. When we dissect and transect that carotid artery, we want to make sure that no clots are forming, and so they'll ask for that IV heparin. And like I said, this is usually a one-time occurrence. However, it is absolutely acceptable to ask your surgeon, do you want me to add this to your preference card, or is this just a one-time thing? And they'll let you know. All right, STAT. This is also usually given verbally, and this is immediately the medications are needed, and it's a one-time only event. Common ones during surgery are drugs that we may be giving during a code. If heaven forbid our patient codes on us, there will be emergency medications that need to be given. Or the malignant hypothermia. Obviously, this is an emergent situation too that is a one-time only thing, but the surgeon's going to call for that dantrolene. And so those are examples of STAT orders. And finally, we have PRN. This stands for pro renata, and it simply means given as needed. For instance, during a septoplasty, we may have Demerol on the back table to be given as needed for pain if the patient is under a local anesthesia. Okay, it's not an always thing, it's just a given as needed, and usually it will be listed on the preference card if they want that given. Okay, rents routinely needed during procedures are listed on the preference card, as I said. It's going to list the name, the strength, and the volume of the drug. That's how it's going to read on the preference card. So for example, if we're doing a cholecystectomy and we need to add some dye to see if there are any stones in the duct, the preference card may say Omnipaque 300, 10 milliliters. And that lets us know that we need 10 mLs of the Omnipaque for that procedure. So unlike the floor units, though, there is no route or frequency listed on the preference card. Okay. There are some abbreviations that are used for drug forms, such as dosage, medication strength, the percentage, routes, and timing, things for that. They're usually in the metric system, which we will have a review of when we get to Chapter 3. So for example, lidocaine used for local in the field during a surgery will be on the preference card, and it's going to say lidocaine, 1% plain, 30 mLs. And that's what, like I said, lets us know that that should be on the back table, drawn up, labeled, and ready for use. And then as a scrub, you're going to want to make sure at the end of the surgery that you're letting your circulator know the final amount of the medications used, because that will go into the patient's records, how much meds we've given. Okay, so we have hospital orders as well. These are going to be on the floor. And the route of administration is also another abbreviation that will be used. Those are listed on page or in table 1.4, which you can find on page 7. Like I said, these are the abbreviations that we're not going to see on the preference card, because it's going to say the route of administration, and obviously in surgery our route's usually going to be IV. But it will also, the hospital orders will include frequency, which is another abbreviation table, also on page 7. For example, if a patient is getting a certain medication 3 times a day, that abbreviation is TID. T is in Tom, I, D is in dog. And that signifies 3 times a day. So obviously, again, these are things that we're not going to see on our preference card, but it is a type of abbreviation that's used quite often in the hospital. So you may see it from here to there. Okay, so moving on, we have some different distribution systems. The drugs are dispensed, which means released by pharmacists, and there are a few different variations on the hospital pharmacy. So we have the main hospital pharmacy, which releases what is needed as needed, PRN. They also do any kind of special antibiotic preparations, a lot of which we need in surgery. There's a lot of variations that we will use on different drugs, and they would do that for us. They would get those ready, and then the pharmacist will bring it down to the OR and drop it off for that particular case and doctor, or the nurse will go and get it from the pharmacy. Okay. A lot of the bigger facilities with many ORs will have what's called an OR satellite pharmacy. This is a space that's set aside in the OR, and it is the OR's basically its own personal pharmacy with a pharmacist on site. And they will prepare everything that we need for them there, right there in the OR. They're usually in containers that are labeled per procedure. When the procedure is finished, the nurse will return that container to the OR satellite pharmacy, and from there they'll inventory it, what's been used, they'll bill for it, and then they'll restock it so it's ready to go for the next case. Then we also have OR med rooms and carts. So these are usually standard items needed. They are pulled per preference card per case by the nurse. They are charged for on the patient record, and those are also restocked by our pharmacist PRN. Okay, those are our med rooms. By the carts, what I mean by those, these are our crash carts. That's a good example of one. So if a patient is coding, we'll have what's called a crash cart, and that's going to have our medications that we may need for an emergent code. It's going to have our defibrillator on top, and those then, if obviously they're used, then they'll be restocked and inventoried. They're also opened up and checked on a regular basis for outdates and things like that. Another good example of that would be the MH cart. That also is going to be checked and outdated and inventoried on a regular basis. But if used, then it would go back to the pharmacy to be restocked. Okay, so here we have some examples of those carts. So this one here on the left, this is going to be in the actual OR suite, usually up by anesthesia. And you can see here that there's a spot here. This is a lock, and right above here is a fingerprint scanner. So the anesthesiologist will scan their fingerprint. That will unlock the system, and the patient log then for surgery for the day will come up on this computer screen here. The anesthesiologist is going to pick their patient. They're going to pick what drug they want, and then the appropriate drawer out of all of these little spaces here, the appropriate drawer is going to open up so that they can take the drug that they need out. They then are going to scan it. This here is a barcode scanner. So they're going to scan that barcode as a second step to double check that they have the correct patient and the correct drug that they want. These computer automated carts have really done a good job of minimizing medication errors with these barcode scanning technology that we have now. Okay, so in the middle, it's the same basic concept. It's just a big one of basically a giant OR cart. This would be a good example of one of those OR satellite pharmacies. So there may be a pharmacist that also is on staff here, mixing and preparing any kind of as-needed specialty drugs. Otherwise, our circulators can also, in anesthesia, can access this same thing. They'll fingerprint scan, and then you can see a keyboard comes up here. They can type in their patient name and what drug they are looking for. That will pull up here. She then selects it on the screen, and the appropriate one of these drawers or doors will open for her to get the med. And then you will see there's another barcode here where they will scan it again. And then this one over here on the right is the same thing, again, just on a larger scale, and this is where you would find, or what you would find in the OR in those med rooms. So it's the same system, just on a larger scale, and this usually is stocked regularly, and this has enough drugs to get the entire OR through the day. So that's what we would find in one of those med rooms. Okay, now we're going to get into some drug forms and preparations. Okay, so a drug form, this is just how it appears, okay, how it's prepared, and it's how it's administered. The form of the drug affects both the onset of its actions and the intensity of the body's response to it. Okay, so for instance, liquids act more quickly than solids, and gases and vapors act even faster than liquids. In fact, gases and vapors are the fastest acting type of medication. Okay, some are available in more than one form. An example of that would be our 2% lidocaine, which is a local drug, local anesthetic. It can be in a jelly form for topical administration, or it can be a solution of various strengths for injection. Okay, there is a table, again, table 1.5 on page 7 of your text. That is a great table to note and study as well. That will give you the different abbreviations for the forms of drugs, and there are some strange ones, like for example in ointment, the abbreviation for ointment is UNG. Some are a little more obvious, like tablets are TAB, capsules CAP, but that ointment that's a strange one, UNG. Okay, so take a look at that table. Okay, so going forward, there are 4 main drug forms. The first of which are solids. Okay, so these can be capsule or tablet, and they are administered orally. Capsules are the gelatin cases, so you'll see that over here on the right. And this gelatin case then contains the drug in either a powder or a granular form. So that capsule is going to be taken orally, the gelatin will dissolve, and the drug will then be dispensed systemically that way. Okay, and then we have tablets, which is this one here. Those are compressed form of the drug, and then they're combined with some inert ingredients. So these two down here are caps and our tablets. These are rarely used in surgery for obvious reasons. Our patients are usually nothing by mouth for several hours before surgery. And the more obvious is that, well, our patients are sleeping. They are sleeping, they have a tube in their throat that is breathing for them, so obviously they are not going to be able to take any kind of tablets or capsules. Excuse me. Okay, our solid drugs can also come in powder form. These are going to be in glass vials. They usually need to be reconstituted, which is a fancy word for mixed. with a liquid to form the solution for injection, usually either sterile water or saline. And a good example of this is our antibiotics. Those usually come in a powder form and are reconstituted, usually in saline for irrigation. And then our good friend dantrolene up here, Dantrium, for our malignant hypothermia. If you guys remember correctly, that gets mixed with 60 cc's of sterile water, shaken up to dissolve, and then it is administered by injection. Okay, next we have semi-solids. These are going to be your creams, foams, gels, and ointments. Remember, that's where I said that weird abbreviation for ointment comes in, UNG. Okay, creams are usually the active ingredients in a water base. Ointments are your active ingredients in oil, lanolin, or a petroleum base. Gels, those are thicker than most creams, but they are still also in a water base. Okay, and examples used in surgery, again, are that xylocaine jelly for topical anesthesia. Silvadene, which I have a picture of here, is used for burns. Estrogen, we talked about earlier, for vaginal packing. And then we'll use Neosporin or bacitracin. That's a topical semi-solid that we will put on surgical wounds to help fight off infection while they're healing. So those are some good forms of and examples of what we would use in surgery. All right, guys, hang in there. Believe it or not, we're actually halfway through this lesson, and I'm going to lose my voice. Okay, next we have the liquids. There are 3 different types of liquids that we're going to learn about. They are the most important, and that's what we'll use in surgery most often. So the first one we're going to talk about is a solution. So this is a mixture of drug particles, which is known as a solute, and they're fully dissolved in a liquid, which is the solvent. That's usually going to be sodium chloride, which is that NaCl, or water. Some common ones that you'll have on your back table as a scrub tech. Those include the sodium chloride, antibiotic irrigation. So we may dissolve some Ancef powder into the saline and make an antibiotic irrigation out of it. Heparin irrigations, we'll use those quite often. And Afrin, we'll use that as a nasal spray quite often as well. Okay. Then we have the suspensions. These are solid, undissolved particles that are floating in a liquid. Right? Suspensions, they should be shaken before they're given. And the reason for that is to evenly distribute those particles through the solution. Okay? A good example of this is codosporin otic. We use this in ENT, mainly in the ear surgeries, and that's an anti-inflammatory and an antibiotic. So we'll shake that up or just roll the syringe through your fingers as a surg tech and hand that to your surgeon, and that just makes sure that those solvent or solutes are evenly distributed through there, so they're getting an even amount in every drop. Okay, then we have the emulsions. So this is a medication that's contained in a mix of water and oil. Okay, and it's bound together by an emulsifier. That is something that mixes those 2 substances together that wouldn't normally mix, like the water and oil. There is a good example of this in your household, and that is mayonnaise. So egg yolks, they contain a chemical called lecithin, and that's what binds the egg yolks and the oil together so they don't separate, and it keeps your mayonnaise. Okay, so meds are usually oil and water or water and oil, like we discussed a couple slides back. So in surgery, we commonly use Diprovan. It's also known as propofol. Okay, it's a sedative and a hypnotic. We give it to IV to induce the general anesthesia. So lecithin, is also found in propofol. So you'll hear your anesthesia providers a lot of times ask your patient if they are allergic to eggs. And that's why it has that lecithin in there. So it is contraindicated to use Diprovan, and we would find they would use another type of anesthesia to give. Okay, it's good to note also that liquids may also be known as elixirs, which are sweetened alcohol, or syrups, which are sweetened aqueous solutions. Again, we don't use these in surgery because they're administered orally, but it's a good thing to note that that is another type of liquid drug form. Okay, last but not least, we have the gases. So a common one that we use a lot and hear a lot is nitrous oxide. I'm sure you guys are all familiar with that. You've heard it before. We'll use that a lot in dental offices, for example. One that we would use in surgery a lot is desflurane. This is actually a liquid. We call it a volatile liquid because as it runs through the anesthesia machine, it is turned into a gas form for administration. So that's what they're breathing in. But it does start as a liquid. And as we said earlier, gases tend to act more quickly than the other forms of all those drugs. Okay, gases are the fastest acting. Okay, so now we're going to get into some administration routes. There are two main ones. The first one being enteral. Okay, this means that it is taken into the GI tract directly. Okay, these are primarily going to be taken orally, which is what that PO means. Per os is orally. This is the most common way to administer the drugs. This is where our tablets and capsules are swallowed. That's where that comes in. And they're absorbed into the GI tract. Okay, the onset of these drugs, the enteral routes, is usually slower. So they take a little longer to get going. But the duration of the effect is also longer. So that active medication, that's going to be active in your system a lot longer. Okay. These certain drugs are inactivated by digestive enzymes, and they shouldn't be given orally. And an example of those, like we talked about earlier, would be the insulin and the heparin. Those are proteins, and as soon as we we take in proteins orally, they begin to get digested. So that's a good example of those. We don't want to give orally. Okay, the other option, the other route is parenteral. And this just means any route other than the digestive tract. Okay. It should be noted too, the majority of meds in surgery are given by the parenteral route, obviously, because we're not giving oral drugs during surgery. And there's a few of them to go over. So topical. These are intended for application to the skin or the mucous membranes. Okay, some work at the site for application for a local effect. These are going to be like your steroid creams, like hydrocortisone or neosporin. And some work throughout the body for a systemic effect. Okay, so these are going to be our antibiotic irrigations, heparin irrigations, pontocaine drops we give in eyes. We've already gone over Afrin, and also our anesthesia gases. Okay. Another example of a topical drug that your techs use is methylene blue. So this is a blue dye, basically, that is instilled into the uterus through a cervical cannula. And it's called, the procedure itself is called a chromotubation. And what we're using this for is infertility. So we are checking to see if those fallopian tubes are patent, if they're active, if they're working properly. Okay. So the dye enters the uterus, and then it's going to exit the uterus into the fallopian tubes, and then from there it's going to leak into the pelvic cavity. We'll use a laparoscope to observe that blue dye coming out, and if we see it exit the fallopian tubes through the fimbrium into the pelvic cavity, well then we know that that tube is patent, it is working. So it will release an egg, and that egg will be able to get through the uterus for fertilization. So that's a good example of using a topical. Okay, and then like I said, the anesthesia gases. Inhalation is considered a topical administration. Asthmatics we'll use inhalers and nebulizers. That's another example of converting a liquid into a mist that we can inhale. It's absorbed in the branch of the lungs. In surgery, the gases are inhaled, and those are systemic effects as well. And like I said, those are almost immediate. Okay, we have subcutaneous. This administration route is given just below the skin into the subcutaneous layer. Common sites for this are usually the upper arm, the thigh, or the abdomen. The absorption for this is fairly rapid. And examples that we use in surgery, most common is going to be heparin. During cardiothoracic surgery, we will give a subcutaneous little dose of heparin to prevent any kind of PEs, pulmonary embolisms. IM. This is intramuscular. It's usually given in a large muscle mass like your deltoid, your gluteus, or the vastus lateralis, which is your quadricep. It's very rapid absorption, usually due to the large absorbing surface of the muscle, and we all know muscles have great blood supply, especially those large ones. And the better the blood supply, the faster the absorption is going to go. Okay, an example that we use in surgery is Toradol. It's an anti-inflammatory, and we use it for pain relief. That's usually given at IM. And locals. Locals are used in surgery all the time once that surgical wound is open, towards the end of the case or at the beginning. We'll inject that local into multiple layers, including the muscles, as needed for pain control during and after for a time the surgery is done. And then we have IV. So this is the most common and most widely used parenteral route in surgery. Okay, it's given through the vein. A small catheter is inserted into the vein pre-op, and it's connected to some tubing called an infusion set. Okay, that set's connected to a bag of fluid for administration, usually that saline. And then the drugs are injected through port sites along that tubing. So it can be given all at once, the drugs, which you'll hear called a bolus, or it can be given slowly over time as an infusion throughout the procedure. And I want you guys to note that the absorption for an IV is immediate. It is going directly into the bloodstream, so that drug is going to act almost immediately. Okay, and there's another page, like I said, table, page 7, 1.4. Those are the administration abbreviations. So take a look at these tables, guys. They are great study guides for you. So there's a few other less frequent parenteral routes. And this is where, like I said, that medical terminology is going to come in helpful. Intradermal. Intra meaning between, and dermal meaning skin. So these are given between the layers of skin. An example of this, and especially going forward when you get into healthcare and working, you will have to have an annual TB test, so your tuberculosis testing. That is an injection that is given in between the layers of your skin that you then have to go back, I think it's 72 hours later, to have read for any kind of reaction. If any of you have ever had allergy testing before, those are also intradermal injections. They are given just below and in between the layers of your skin. Okay, then we have intra-articular. So if we break that apart, intra is between or within, and art is a joint space. So this is going to be into a joint space. A good example, usually it's steroids or anti-inflammatories or locals. So for instance, if we've just done a knee arthroscopy, we've just done a knee scope, they may put some steroid in there for any kind of anti-inflammatories that might be going on. And then we have intrathecal. So this is local that's injected into the subarachnoid space of the spine. And then that local is distributed and diffused in the cerebrospinal fluid. So for example, if any of you have ever heard or seen an epidural, this is where that intrathecal is going on, okay? It's in the spine, it's going to get diffused into the CSF, and that's what's going to cause that numbness from whatever level down. Okay, and then an even less frequently used one is during CPR, and we may give an intracardiac injection, and that is when epinephrine is injected directly into the heart. Not used very often, thank goodness. Okay, next we are going. Okay, so now we're going to move on to pharmacokinetics. This is just a great big fancy word for what the body does to drugs. Okay, it studies the medication from administration through 4 basic processes, which we will go through. It's a good thing to note that the patient's general health significantly affects how the body processes drugs. So for example, if their liver or kidney function is compromised, so is the ability to process drugs that we're giving them. Okay, so that is something to keep note of. Okay, so the first one, like I said, there's 4 major areas that we're going to cover. The first is absorption. This is the process by which the drug is taken into the body. It moves from the site of administration into the bloodstream and then into systemic circulation. Okay, absorption rate is the speed of absorption. This is affected by the administration route, blood supply to the area, and the solubility of the drug, or how its ability to be dissolved. If a drug is in solid form, it has to dissolve before it can be absorbed. Okay, drugs and suspensions dissolve faster than solids, and solutions even faster than suspensions. Okay, so oral absorption, that varies depending on the drug. It depends on their chemical structure, as well as their pH, the acidity, or the motility of the GI tract. So if the tract is highly motile, like if a patient has diarrhea, for example, the drug may not be adequately absorbed because it is just simply moving too fast through the digestive tract with that diarrhea. And then, as you can imagine, the opposite may happen if the patient's constipated. That drug may not get absorbed because it's just not moving through the GI tract as it should. Okay, IM absorption, so that intramuscular, it's rapid if it's water-based and slower if it's alcohol-based, or I'm sorry, oil-based. And the vascularization of the muscle, like we said, that also affects the absorption rate. Blood flow has a direct effect on absorption. Okay, and then we said IV absorption, obviously the intravenous, that is immediate. Those drugs are going directly into the vein through that catheter and directly into the bloodstream for distribution. So those are immediate, the IV. And then drugs that are inhaled, those are also very, very rapidly absorbed because of the large number of capillaries that are in the mucous membranes. So those mucosal sites, those can be the respiratory tract, the oral cavity, and the conjunctiva of the eye. Okay, those are all highly, highly capillarized areas, so that absorption is very, very rapid there as well. And some are made to be absorbed through the skin, so that's just something to keep in mind as well. These are going to be our patches. Scopolamine, for example, is a small patch that goes behind the ear. It's made for motion sickness. You will also see that used quite a bit by the anesthesia providers. If the patient is susceptible to nausea after anesthesia, they may put a scopolamine patch on them. Okay. So then we have distribution. So the circulatory system transports the drug through the body. Eventually, the drug molecules diffuse out of the bloodstream and into their intended sites. Okay, so bioavailability. This is the degree to which the drug reaches its site to exert its effects. It may be affected by a condition of the circulatory system, so tissue perfusion, acid-base balance, and plasma protein binding. These are also things that will affect distribution. And we'll talk just a little bit about them as well, but that Insight 1.3 is a really good explanation. So the acid-base balance, an example used in surgery is local anesthetic. So it's a weak base, and if it's injected into an infected wound, which is a very acidic environment, then that agent becomes ionized and it can't reach the membrane of the nerves. So the effect is very delayed. A good example of this is at your dentist's office. If you are going in to get a crown or a root canal or a tooth extraction, and there's an infection there in your gums, if you have an abscess or anything like that, they will send you home on an antibiotic regimen to clear up that infection before you come back and have your dental work done. And the reason for that is that that acidic environment that infection is causing is going to delay the effect of their numbing agents, and they won't be able to numb you up. So that's why they send you home to take care of that infection before they go on with the procedure. And then we have plasma protein binding. So some drug molecules bind to proteins in plasma. It depends on the plasma protein in the blood and the binding characteristics of the drugs. Some are highly bound, some are minimal, and some aren't bound at all. The highly bound drugs, their molecules have a longer duration of action because they stay in the body longer and they have a lower distribution to the site of action. Okay, so plasma protein binding is nonspecific and it's highly competitive. Okay, drug molecules compete with each other for the binding sites. Hazards can arise if patients are taking drugs that compete for similar binding sites. That's where that competitiveness comes in. And a good example of this is a patient that's taking Coumadin, which is an anticoagulant. If that patient is also taking aspirin, the aspirin will bind with the same sites as the Coumadin, making more Coumadin available than what is needed. And now we have extremely thin blood, and we have excessive anticoagulation. Okay, highly bound drugs in surgery include Diprivan, fentanyl, and diazepam. These are all anesthetic agents, but it needs to be noted that this is reversible. Okay, so if this competition happens, they are all reversible. We can fix it. And then we have biotransformation. So biotransformation is a fancy word for metabolism. Okay, this is turning lipid-soluble drug molecules into water-soluble drug molecules. The liver is the primary site for metabolism. It can also happen in plasma, lungs, and the GI tract and kidneys, but the liver is the primary site. Okay, the liver breaks down the drug molecules into other drug molecules, which are called metabolites. Only unbound or bioactive molecules can be transformed. Most are, though, at least partially transformed, but only those unbound ones are going to be completely transformed. Okay. Some drugs are administered in an inactive form, and then once they are broken down, they become active. So like I've said here, a good example of that is omeprazole, which is a PPI, a proton pump inhibitor. So once that omeprazole gets into your stomach, it is broken down, and what it does is it inhibits those proton pumps and inhibits the overproduction of gastric acid. So this is a heartburn medication. Okay. All drugs are taken orally, enter the liver through the hepatic circulation. They go through a first pass effect, something that's called a first pass effect, which means they may be altered or nearly inactivated when they go through the liver. Once those liver enzymes begin the transformations, enzymes are less able to break down the drug. That's why we use repeated dosing. That's used to work against it. Okay. So that is biotransformation, drug metabolism. And finally, we have excretion. So medications taken into the body, they're eliminated, usually through bile, feces, or the skin, but the most common, most are excreted through the kidneys and eliminated through the urine. What happens there is the circulatory system brings blood to the kidneys where it's filtered and returned. And there are two renal processes two renal filtration processes that this happens through. I can never say this word, you guys. Glomerular filtration. This is only drugs not bound to plasma proteins. Those are the ones that will be filtered out of the blood plasma and into the glomerulus. How much is filtered out depends on that filtration rate, which also depends on blood pressure and blood flow to the kidney. Okay, the second one is tubular secretion. This uses cellular energy to force the drugs and metabolites from the blood. Okay, some drugs, depending on characteristics, may be reabsorbed and returned to circulation. Okay, factors influencing renal elimination are kidney disease, the pH of the urine, and the concentration of the drug molecules in the urine. Okay, but what I want you to really take away from that is all of the drugs that we take into our bodies are secreted through the kidneys and urine. Okay, another side note is that those volatile gases that we had discussed earlier, those are excreted by the lungs. So when surgery is done, we will put oxygen on the patient, and that is to help them breathe and really, really fill up those lungs with good oxygen to excrete those gases from their system. Okay. Keep calm, guys. We're almost there. All right. Last but not least, we have pharmacodynamics. So this is also a big fancy word. And basically what it is, this is a great big fancy word for what drugs do to the body. Okay, this is what they are doing to us once they are in us. So the agonists, these cause specific responses and then they attract to specific cells. Okay, so this is like a lock and key. They have an affinity for a receptor and they cause a certain response. Okay, so this key goes into the lock and it will open the door. So they are very specific. Natural agonists include acetylcholine and hormones. Synthetic agonists is a succinylcholine, which we will use. It's a muscle relaxant that we use in surgery. Okay, but I want you to take away that these agonists cause specific reactions, and it's like a key that is specific to a lock and it will open the door. Those are your agonists. Okay, then we have antagonists. The antagonists bind to a receptor and they prevent a response. Okay, this is still a lock and a key, but this key will go into the lock, but it won't turn. So it's not going to work. Okay, these are also called receptor blockers. Your antagonists are receptor blockers. Okay, they might be competitive, which means they bind to prevent an agonist from reaching, or non-competitive. Okay, the antagonist alters the target site, preventing the agonist from causing an intended effect. Okay, so they are competitive, and they can be non-competitive as well. They're responsible for many, many drug interactions. These guys are kind of a pain. Many patients may receive multiple drug therapies, so the chances of these interactions is increased. For example, we talked about earlier Coumadin and the overproduction of the anticoagulations if they're also taking aspirin. So that's a good example of that competitive antagonist. Remember, we also said that they can be reversed. Vitamin K can reverse that effect. Okay. Another example of this would be amoxicillin. Amoxicillin, as we know, it's a common antibiotic, but it can reduce the effect of oral contraceptives. So your physician may ask you if you're taking any forms of birth control before he decides which antibiotic to give you, and that would be an example of that. Amoxicillin can reduce the effectiveness of those. Okay. And we have the synergists. So these synergists enhance the effect of other drugs. They may also interact with vitamins, minerals, and other herbal supplements. An example is tetracycline. That's compromised when it's combined with dairy. Or penicillin. Penicillin inhibits the formation of bacterial cell walls. So these are things that the synergists do. They enhance the effect of other drugs. Okay, so dairy would be a synergist to tetracycline. Okay, and the last thing we're going to cover for this chapter here are some terms that you as a surgical technologist should be familiar with regarding the drugs and the surgical patients. So the first one is the indications. The indications are the reason or purpose for giving the medication. This is why we are doing it. Okay. The contraindication is a reason against giving the drugs. So again, I'll bring up that example of Tylenol versus Coumadin. It is contraindicated to give Tylenol if they are taking Coumadin as well. Okay. Onset. The onset is the time between administration of the drug and the first appearance of the effects. So how long it takes from the time we take that aspirin to the time that the headache starts to go away. That is the onset. Okay, the time between administration and maximum effect is called time to peak effect. That's something you guys will need to know, time to peak effect. And that is onset or administration to maximum effect. Time to peak effect. And we have duration. This is the time between onset and disappearance of the drug. So the time that we take it and it starts working until it's out of our system. That is the duration. Now there is something called a drug half-life. And the drug half-life is the length of time the drug concentration is in the therapeutic range. So the time in which it's actually doing what it needs to be doing, that's the half-life. Okay, then we have side effects. So side effects are expected, they're predictable, but they're also unintended. So they're an unintended effect of the drug. A good example or an easy example of this would be Benadryl. Benadryl makes me drowsy. It's not unexpected, it's predictable, but it's not intended for that to happen. And I know some people, the opposite happens, where they may take a Benadryl and it makes them very hyper. Also expected, predictable, but not the intended effect of the drug. That is a side effect. Then we have the adverse effect. So this is an undesired and potentially harmful side effect. Examples of this are nausea, vomiting, drug toxicity, hypersensitivity, and IDR, which we will go over in just a second. I have hiccups. Okay, so hypersensitivity. This is an adverse effect resulting from a previous exposure to the drug or a similar drug. That could be mild, it could be severe, and an example of mild versus severe would be hives versus anaphylaxis, which is where your throat and respiratory system is affected and starts to close. A good thing to know about this is that hypersensitivity can be delayed. You may take a certain drug several times over your lifetime, and then all of a sudden, one day you take it and it causes hives. You've developed a hypersensitivity to that drug. Okay. And then we have IDR, idiosyncratic drug reactions. These are basically I'm not sure of adverse reactions. The mechanism of the effect is unknown. We just don't know why it happened. They're very rare. These reactions, extremely rare, very unpredictable. I guess a surgical example that I could give you would be the malignant hypothermia. That is an adverse effect to those volatile liquids that we are using as gases. So that would be a good example of a surgical IDR. Okay. And that's it. You guys made it. Chapter 1. We're done. Hopefully it wasn't too bad, wasn't too terrible. If you have any questions, comments, concerns, please go ahead and include them in the Ed puzzle here. And I will see you guys in a little while for class. We'll go over this and we'll move on. All right, guys. We'll see you in a bit.